All right, we'll continue the note on antiarrhythmic drug choices. Now, with atrial fibrillation, the choice of antiarrhythmic drug, if there is no structural heart disease, then your first line would be 1C medications and sotalol, flecainide, propafenone, sotalol. Sotalol is a class 3. If those don't work, then you can move on to difidolide and amiodarone, which are the rest of the class 3. I always like to think of amiodarone as the last resort, or the secret weapon, more so than a last resort, because it is the first line in other situations where other medications don't work. So be careful of renal function for difidolide and sotalol. Again, a lot of our patients might have ischemic symptoms, shock, and systemic hypoperfusion. Remember to avoid sotalol in heart failure. You may not give sotalol in heart failure. Remember the SWORD trial. You cannot give sotalol in heart failure, just to be very clear. So whenever you see an atrial fibrillation patient, you want to know, is there a structural heart disease or a scar? Is there a coronary artery disease? And is there a heart failure? If the patient has coronary artery disease, then your first and second line would all be class 3, difidolide, sotalol, and then amiodarone. And you want to be careful again in renal function for difidolide and sotalol. I can't repeat that enough. For the heart failure patient, if the patient is going to receive a medication, it's going to be class 3 medication. Be careful of renal function with difidolide. Sotalol has no role in heart failure. Again, SWORD trial. Remember, sotalol, no heart failure role. We mentioned this in this point, and now in heart failure, we give amiodarone and difidolide. Difidolide can be given in renal function, cannot be given with bad renal function. You want to test for renal function. Be careful in liver dysfunction and heart failure, hypoperfusion, and or ischemia and shock, because again, our cardiac conditions can cause liver congestion and ischemia because of the cardiogenic shock. And liver is needed to metabolize amiodarone, so that can exacerbate a lot of liver damage and lack of clearance of amiodarone, and then proarrhythmic effect and QT prolongation. In heart failure and highly symptomatic patients, amiodarone is preferred over difidolide and can be given with poor renal function. So it can be tolerated with poor renal function. So drug interactions is one of the things that are really, they're a difficult thing to address in antiarrhythmic medications. And interruption is dangerous in general. You want to advise your patients once they're taking it that they're going to be compliant to it, and that whenever they see any other physician that they disclaim that they're taking it, and they always reconciliate their medications with their cardiologists. Don't skip, don't double doses. That goes without saying. Ventricular tachycardia. Again, this is from the Mayo Clinic Foundation. And so are all the blue slides. I took those from the Mayo Clinic Foundation presentations. Substrates, structural heart disease or normal heart. Again, structural heart disease includes a pre-existing scar, right? And an active ischemia, as we discussed in the previous note, in the previous video, at the very beginning, there is a difference between ongoing ischemia, because that affects the way that electrolytes moves, the way that energy is utilized because of ischemia, the way that ATP dependent transporters will function, and so on. So these are important to keep in mind. For the normal heart, we have, again, you want to look for polymorphic or monomorphic. So in a structural heart disease, the monomorphic will be in some stable structural issue. There's a scar and you go around it. Of course, the terminology of going around the scar is actually flawed. It's usually that there's some viable conduction through a scar that creates a stable pathway. That's discussion for another time. But coronary artery disease that's stable, dilated cardiomyopathy, ARVD, sarcoidosis, they're all structural issues. And in those cases, and in all the cases, luckily, whether structural normal, whether mono or polymorphic, beta blockers constitute our first line, okay? So beta blockers will constitute our first line. And when we talk about structural heart and normal heart, we're not talking about a heart without, so this is a little confusing. We're not talking about a heart without any disease. We just mean that the heart is structurally normal. So the heart is structurally normal. I should probably clarify that. So normal heart, structurally normal, but may have channelopathies. And so beta blockers for long QT and flecainide for CPVT, quinidine for Brugada syndrome. Flecainide for CPVT, possibility, quinidine for Brugada syndrome. You won't be questioned on those, but you will be questioned about quinidine and Brugada in the context of shock. So patient with Brugada syndrome receiving multiple shocks, what do? You give quinidine to reduce the shocks. In fact, you can give quinidine in patients who are receiving multiple shocks anyways with device therapy or frequent cardioversions to reduce the load of tachycardias. Okay, and so if that's for the polymorphic, and the polymorphics, the channelopathies are usually polymorphic, and this is kind of, it's a way to make you remember that. Fast VT, you can give a calcium channel blocker. Other antiarrhythmic other than beta blockers in a monomorphic structurally normal heart are rare simply because these are usually benign. You want to look for bigeminal beats. You want to, the most common location for a benign monomorphic VT is the RVOT, and then LVOT and fascicular VT can also be seen. Okay, so these are the easy ones, and we put them aside. Channelopathies, probably I will discuss those separately at a later point. For the structural heart diseases, if it's a monomorphic, beta, amiodarone, sotalol, these are all your first line, but sotalol, again, avoiding heart failure. So see how many times that point is repeated. You will definitely be questioned about that. Avoid class 1C, avoid class 1A. Again, these are the contraindications in structural hearts. No sotalol, no class 1C, and no class 1A if you really don't need it. You have better classes, you have the beta blockers, and amiodarone specifically amongst the class 3 medications. But remember, as we showed with the atrial fibrillation, if there is no structural heart disease, then you can use some of the class 1C. Class 1A don't have a lot of role here, and if the patient has a structural heart disease, then you automatically go to class 3. For the VT, amiodarone is preferred over other class 3 medications. Okay, for polymorphic VT and ongoing ischemia, again, beta blockers, lidocaine plus minus amiodarone. Just be careful with renal impairment and interaction. So those are important. And you always be careful of renal and liver impairment in the context of acute arrhythmia or acute in the context of acute arrhythmia or the context of acute MI. All right. What about interaction? So this you can pause and go back to it. Okay. Again, it's from the Mayo Clinic Foundation, but this is how I break it down in a way that makes sense. And now these points will actually discuss everything in this figure above, but with more nuances in relation to real cases. So the enzyme inhibitor effect of amiodarone, right? If you have an enzyme inhibitor, if you give amiodarone will actually inhibit enzymes that metabolize, so the cytochromes that metabolize warfarin. We give warfarin a lot because of our structural diseases, because of our valves, because of anticoagulation indications, right? Hookham patients, mechanical valves, severe rheumatic stenosis, things like that. Digoxin and cyclosporin tacrolimus for our patients. These are both calcineurin inhibitors for our patients with heart failure. Calcineurin inhibitors, they work on the IL-2 pathway. So it's really important to note and be very careful about these because they will increase with amiodarone. Okay, so again, what do I do with amiodarone once I prescribe it? I look for renal failure. It's okay because the rules are in all antiarrhythmics. I look for renal liver, then think which one is renally excreted, which one is hepatically excreted. So amiodarone is okay with renal, and I look for drug-drug interaction. And here it's warfarin, digoxin, cyclosporin, tacrolimus. So which cytochromes are really important? So there are effects on the cytochrome P2D6. 2D6 mutations, 2D6 metabolizes, meaning if the cytochrome 2D6 is mutated or inhibited, then all of the following drugs will increase. They'll be at toxic levels because they are metabolized by this enzyme. If it is mutated and dysfunctional and does not metabolize, the drugs will not be cleared and you will have toxicity. So again, propafenone, flecainide. Remember, I started the very discussion on antiarrhythmic drugs with flecainide because flecainide comes up in most of the sections that we've discussed so far. So propafenone and flecainide, and I highlighted also carvedilol. These are the three ones you're likely to be tested upon. Mexiletine, again, is the oral form of flecainide. It's not usually tested. Propranolol is a beta blocker, and we don't have a lot of utility for it in cardiology per se. Propranolol is actually, interestingly, structurally similar to propafenone, and they could both have effects on vasoactivity, but the indications are different, even though they have some structural similarity that causes them to act similarly. I think propranolol has one side chain extra to propafenone. So flecainide and mexiletine, we use them for MI and structural heart disease because they don't widen the QRS and therefore they do not precipitate proarrhythmias. They have fast kinetics, but we want to be careful not to give them when we have a shock state and their metabolism may be abnormal because they're metabolized by the liver, and if the liver is congested, again, they're metabolized by this enzyme. This enzyme's in the liver. And automatically you would know any liver disease is going to affect all of these enzymes, all of the cytochromes. So this is a really easy backhand to think of how to approach medication toxicity on the boards if you have an MI in cardiogenic shock or heart failure in cardiogenic shock. So those are the mutation. That's one thing that inhibits the activity of the enzyme because the enzyme is dysfunctional. Okay, what if the enzyme is normal, but we give a medication that inhibits it? So drug-drug interaction. So inhibitors, meaning the ones that will potentiate the toxicity of the drug. So amiodarone will inhibit it and will cause toxicity of those drugs. So anyone here will inhibit anyone there. Will inhibit this enzyme and increase the toxicity of anyone there. Amiodarone, fluoxetine, paroxetine, quinidine, and sertraline. Notice that only quinidine and amiodarone are class 1 and class 3 antiarrhythmics. The rest are psychiatric medications, and they are commonly tested on the board. Psychiatric medications. In fact, if you don't know, just automatically think that the psychiatric medication, if you're not sure, it's relatively safe to guess that the psychiatric, especially antidepressant medications, are gonna inhibit enzymes and increase toxicity of our antiarrhythmic drugs, usually by means of affecting QT interval. That's also because they have an inherent QT prolonging effect, and it's a good idea to go back to QT prolonging effect databases. There are multiple ones online to check medications because the list is long, but you need to just be in the right frame of mind, and you'll be able to approach all of those. What about cytochrome P3A4? Metabolized, meaning dysfunction of this cytochrome will cause toxicity. Again, the same idea. So if you inhibit it or it's dysfunctional, it's going to increase the toxicity of amiodarone, right? So amiodarone is going to increase here, and it can then inhibit this. So if I have damage to the liver and amiodarone toxicity occurs and amiodarone is in the system, it can further inhibit this and cause toxicity of the other medications. That's why co-administration of medication is something to really be careful about. This toxicity occurs in 20% of cases where A3/4 is inhibited. This is an MCQ question. It's just one of those things you just have to memorize. 20% of cases where A3/4 is inhibited. So that's 1 in 5 patients who have whether drug-drug interaction or liver toxicity that affects the cytochrome P3 or 3A4, they are going to have amiodarone toxicity. The amiodarone toxicity is a syndrome. The constellation is something that you have to know on its own. Dofetilide, the toxicity works exactly as above, thus occurs in about the same number, and in studies have shown 30% of cases where 3A4 is inhibited. Quinidine and dronidarone and verapamil and diltiazem. Okay, so the way to approach these, the medications that will reach toxic levels of CYP3A4 is affected, is I have my class 3 medications, dronidarone and amiodarone. Dronidarone is literally amiodarone's cousin, and they have the same last name, darone. And dofetilide is another class 3 antiarrhythmic. And then quinidine is a 1, and verapamil, diltiazem, they are our cardioactive calcium channel blockers. They're the non-dihydropyridines. I call them our cardioactive calcium channel blockers because they're not long-acting and they're not used for blood pressure. They're usually used to control the heart rate, verapamil and quinidine. I'll have a whole discussion separately in this drug tab on the classification of these medications, calcium channel blockers, and how they differ from each other. For verapamil, it's actually class 4 because all calcium channel blockers are class 4, even though I don't agree or I don't attest to calcium channel blockers and beta blockers to be real antiarrhythmic drugs, but they are class 2 and class 4 medications. So diltiazem, while it's also non-dihydropyridine, it's not structurally the same as verapamil. In fact, they are classified into different medication classes, even though they are both under the non-dihydropyridine heading. Diltiazem is a benzothiazepine, and verapamil is a phenylalkylamine. Both are non-dihydropyridines, and that's different from the dihydropyridines. Cyclosporin, again, cyclosporin toxicity with cytochrome P3A4, and you will also see cyclosporin as a frequently tested fact, and the effect is because of amiodarone. So amiodarone is going to inhibit the CYP2D. So cyclosporin toxicity is something that can happen very frequently. I don't know if cytochrome is metabolized by 2D6. I have that in another note. We'll get to that, but it is potentiated by the amiodarone pathway. I believe it's through 2D6. We'll make sure of that later on, and through the cytochrome P3A4. So what about the inhibitors of cytochrome A3? Again, any drug here will inhibit this enzyme, will cause a toxicity, and any drug up here, any inhibitor will inhibit this enzyme and will cause the toxicity of the drugs up here. So the inhibitors will be diltiazem and cimetidine. They are the ones that are really important. All the macrolides and azole antifungals. So pneumonia and HIV patients and people with antifungals. In our cases, we see the infective endocarditis, very virulent, aggressive on antifungal. They're going for surgery. They might even go before or after surgery, and they get this ventricular tachycardia, and then you want to give them a medication, and so you give them one of those, but the patient is already on one of those, and you go ahead and give them, for example, amiodarone, and they'll have amiodarone toxicity. So that's the way that this would be questioned also on the board. Macrolide antibiotics usually in the context of pneumonia or other infection. You'll be told that the patient is on a macrolide antibiotic. You just need to know them. Okay, so in other words here, diltiazem, the reason why I mentioned that first is because it both inhibits and partially metabolized by the enzyme, so causing a cycle of toxicity. I'm almost tempted to say vicious cycle, but it's not really. But it inhibits the enzyme that metabolizes itself. That's fine because that won't cause toxicity because we studied its dose. That's called the drug's pharmacodynamics. But when there is more inhibitors, then it will potentiate that further. For cimetidine, be careful of questions. In the questions, Tim, you will get a Parkinsonian patient. Please note that the CV boards love testing any cardiac issues related to Parkinson's because Parkinson's will have tremors and will give you ECG artifacts. So almost on every board you'll have a tremor either from cold or Parkinson's, and you'll have ECG artifacts. Cardiac diseases are common during the course of Parkinson's disease. That's why they will ask you outside the context of ECG. They are coronary artery disease, heart failure, autonomic dysfunction, right? A lot of arrhythmias, heart failure, sudden death, and hypertension. Okay, hypertension in Parkinson's disease. And grapefruit juice will also inhibit the cytochrome P3A4, and this is something that they have been testing on the boards in internal medicine and cardiology frequently. Grapefruit juice. Inducers of the cytochrome 3A4, so these will clear the medication out. Remember, we'll just go back for the cytochrome P2D6. There isn't a lot of role for inducers here. There are a few, but they're not as important from a cardiovascular perspective because of the cardiovascular interactions. But for the cytochrome 3A4, inducers play a major role, and they overlap with a lot of our patients too. Channelopathy patients can have seizure disorders, right? And syndromic patients can also have neurologic and seizure disorders. And also in our area, we have a lot of TB, so rifampin is almost always tested on our boards. St. John's wort is tested in the American boards very commonly. So these are the traits in the different countries, different boards. So inducers of the cytochrome P3A4, phenytoin is very important. Remember, a lot of patients can have epileptic disorders. Phenytoin is also class 1B antiarrhythmic, along with lidocaine and mexilitine. But the exam question will bring you a younger patient with known epilepsy and not responding to another antiarrhythmic medication, and we do not use phenytoin that often in cardiac practice. For us, we don't use it as an antiarrhythmic, but the patient that comes to you with an epilepsy and they are not responding and they need another antiarrhythmic for whatever antiarrhythmia. For whatever arrhythmia is ongoing with their epileptic disorder. Phenobarbital will also induce, so phenytoin, phenobarbital, and carbamazepine is one of the most commonly used anti-epileptic drugs nowadays. Okay, so a quick note on St. John's wort, just because we don't see it a lot, is people use it as a supplement for anxiety, depression, ADHD, OCD, and it's all, in my opinion, nonsense. It's not validated. A lot of this is not dangerous. They can use it without significant side effects, but just because it can give any form of toxicity, and just pragmatically speaking, as a cardiologist, I don't like it. It comes from Greek medicine, and hence more commonly seen in the West. There has been studies for all those indications, and there is no evidence to use it. So the body of evidence is good to tell you that it really doesn't work. So let's go on. Knowing this heavy material about inducers and inhibitors, let's talk about practice applications. Knowing all of the above, now that we know the metabolism of the drugs, we know both how they act, QT or QRS. We know what metabolism, how they're metabolized, and that what are the things that potentiate their toxicity, right? And we know exactly what the toxicity is, because the toxicity will be, again, in terms of the QR or QT. It'll be proarrhythmic. So the monitoring should be very logical. If you think about it, you should be able to know what to monitor for. For class 1C, flecainide and propafenone, the ones that mostly affect phase 0, and sodium channels, widening the QRS, barely affecting the QT, better work in fast heart rate because they're use dependent, hence they are great as pill in the pocket approach. Give it with beta blocker for maintenance. And baseline, rule out ischemic disease. Baseline QRS duration. Save the 12-lead ECG to compare later. The ECG should be done when? After 2 weeks of initiation. This is an MCQ question, right? How to monitor for flecainide or propafenone. Baseline ECG, repeat 1 in 2 weeks. You want to consider a stress test at 2 weeks if you have any doubts to see for proarrhythmia, and if the QRS widens by 25%, then you know that this is a proarrhythmic effect. The patients on stress test, if they widen, usually they'll develop a frank VT if you leave them. So when you see, that's why we put the cutoff of 25%. We don't want them to develop arrhythmia and fall, have syncope and fall on the treadmill. So once you see a QRS widening of 10%, that's fine. The therapeutic range, usually the QRS will widen by about 10%, and that's acceptable. For dofetilide, as a class 3 antiarrhythmic, get a baseline renal function with potassium, magnesium levels. Very important. ECG for QTC, document that in the chart, keep as a baseline, compare for future reference. You may start the medication if the baseline QTC is below 440 milliseconds. So this will come as a question. For telemetry on serial ECGs, for the first 5 doses, you want to have the patient on telemetry and serial ECGs just to make sure that everything is okay. If they tolerate it, and then you can go ahead and have lower threshold of monitoring afterwards. I don't even want to say that you don't need telemetry. I like to, if my patients are receiving anything IV, even if they're coming an outpatient, I like to keep them monitored for half an hour in a recovery room at least, even after 5 doses. This is just my clinical practice. Okay, so for ECG follow-up for dofetilide every 3 months, and then compare and assess QT after this initial after the first 3 doses. You'll just continue following up with with ECG every 3 months, assessed with QT. You may want to be prompted to add an ECG to do an ECG if there is new medication added, or you're in doubt that there might be interaction or other cause of QT prolongation. For ibutylide, it's a class 3 medication. Continuous ECG monitoring is recommended for at least 4 hours after completion of ibutylide. For 4 hours, this is very important. Administration or until the corrected QTC interval has returned to baseline. So after completion of ibutylide administration, 4 hours, this should be done in a medical day unit. Monitor for 4 hours until corrected QTC interval. If it is not corrected, you want to monitor them longer until they do. If arrhythmic activity is noted, also monitor them for longer. Sotalol, the other class 3 medication, again, because it's a class 3 and it affects QT, always get potassium, magnesium. Absolutely cannot prescribe without renal panel. This is a medical legal issue. You will be prosecuted if any complication occurs. At least in our system, you'll be liable. Some hospitals will actually have alerts for you to not prescribe without a renal panel. We don't have that. We'll just get alerts for interactions. ECG for QTC, you can start if less than 450 milliseconds. This is a hard exam question because the cutoffs for starting the medications are different from sotalol and dofetilide. Remember, dofetilide is 440, whereas sotalol is 450, just to keep things confusing. There are cutoffs for normal QTC for male and female, and cutoffs for baseline QTC for different medications to start. So sotalol 450 and dofetilide 440. So both dofetilide and sotalol do not specify male or female differences, as opposed to having different diagnostic cutoffs for QTC in male and females. This is just something to clarify and not to get confused. The indication and the QTC that allows you to start is below 450 in sotalol, below 440 in dofetilide, regardless. So that's something to just make your life a little easier. Let's just highlight those because they are medications. And for active recall, the textbook Complete Guides to ECG, they define the prolonged QTC as corrected QTC interval more than 470 milliseconds in male, more or equal to 480 milliseconds in females. There are variable definitions out there, but I absolutely like this definition. QTC interval is divided by the square root of the preceding RR interval to get you the correction. If you have a bundle branch or other pathology that causes significant QRS prolongation, you have to further correct for the QRS. Okay, how do you monitor for amiodarone? Baseline ECG, TFT, AST, ALT. Because amiodarone's liver toxicity is a big deal. Eye exam because they affect vision. Pulmonary function test because they cause pulmonary fibrosis. And chest x-ray. Each and every one of those is a potential exam question, and they should all be done at baseline. Follow-up, you will see the patient in 6 months and order Q6 months for labs. That includes thyroid and liver, because amiodarone can cause hypo and hyperthyroidism. Any one of them, doesn't matter. And then yearly follow-up or ECG, chest x-ray, and an eye exam. Every year, ECG, chest x-ray, eye exam, but the labs every 6 months, including thyroid and liver. They are your labs that you must look up for amiodarone, your energy house and your factory. Again, high yield with all of these drugs can be, you want to be careful when co-administering cardiac medications. Absolutely avoid in bradycardia because of reverse use dependency of amiodarone. The slower the heart, the more likely you're going to get more reverse use dependence and more activity, and you want to avoid an electrolyte imbalance or patients at risk of electrolyte imbalance where you cannot monitor their electrolytes for potassium, magnesium, and to less extent sodium. and even to less extent calcium, but mainly potassium, magnesium. Those are the only two you'll be tested upon. Be careful of administering QT prolonging medications, mainly class 3, followed by class 1A. So the QT prolongation is mainly class 3. For exam purposes, it's mainly class 3. But we know that 1A has a little bit of effect on QT. Our drugs that act on QT prolongations, they're the class 3, all of them, and class 1A a little bit less. In another CVD medication that has a side effect of QT prolongation, and they love to ask about this, ranolazine for stable ischemic heart disease, especially those with refractory angina. I remember having questions for middle-aged women who have prolonged QT that occurred after starting ranolazine, and you just want to identify that ranolazine as the culprit. Okay, and so secondary arrhythmia prescribed. If someone is also prescribed a class 3 medication, then gets ranolazine on top of that, you want to be careful of torsade de pointes. You might get a second order question. You recognize this is prolongation of QT due to ranolazine by interpreting the ECG. That's also one way they can ask you about that. So there are different scenarios that we'll discuss up next.